TopMedTalk. Monty Mythen here. As we prepare to move into the next phase of the COVID crisis, we're going to be widening our focus here on TopMedTalk. We will continue to deliver COVID-specific programs, but we all have a huge additional responsibility as we try to reboot normal services. So although this piece is not directly related to COVID-19, we believe it's information that is crucial to the bigger task of rebuilding the healthcare system as we learn to adapt and live with this new virus. Thank you to our sponsors and to you, our listeners, for helping us to share this important information.
Hi, welcome back to Top Med Talk, live from Anaesthesia 2018, the international meeting of the Royal College of Anaesthetists at the wonderful British Museum. I'm joined by my co-hosts Desiree, Chappell and Joff, Lacey, with special guest Dr Michael Swart. Mike, tell us a little bit about yourself.
Well, I'm a consultant in anaesthesia, perioperative medicine and intensive care in Torbay Hospital down in Devon.
So, Devon, not for the people who don't know Devon geographically, because we do have an international audience listening. Where is it in our country?
It's in
what are some of its features?
It's in the southwest of England, on the coast. It's a very beautiful part of England. It has a mixed population of farmers, fishermen, and a lot of tourism.
And it's one of those places that's quite famous for retirement. So is it got a disproportionately older, but hopefully healthy with it, population?
I think it brings in a large number of retired elderly patients to its hospital, but it also brings in a lot of dynamic doctors who work in a very good healthcare system.
Now, maybe in part it relates to the geography, but your hospital and your area has been well known in our healthcare system, in the National Health Service, for being very innovative, particularly in the perioperative area. We don't have time to go through the whole list, and we'll come to one of your national roles in a second, but in particular, evaluation of risk and communication of risk and shared decision-making.
Well, going back about 20 years ago, my colleague John Carlisle, who is a consultant colleague at the moment but was originally a trainee with us, we got into cardiopulmonary exercise testing. And we got into that through seeing the work of Paul Holder from Melbourne. And what we thought was going to be a very sort of simple, you do a test, you get a measurement, and the man from Del Monte says yes or no to having an operation. We quickly moved to realise that it wasn't about a number, it wasn't actually just about a risk prediction, it was about consultations to find out what patients wanted.
And has it helped? I can understand, I mean, I know quite a lot about cardiopulmonary exercise testing, seen quite a lot of it. I think the patients find it very tangible, because you get on a bike and you're fitter than you expected, or you're as unfit as you thought you were. But let's imagine the patient's very, very unfit now. How do you allow enough time to counsel a patient to allow them to possibly reach a decision that the surgery that they thought they were going to get is now not in their best interest? Sounds very time-consuming.
Well, first of all, you don't have to end the first consultation with a decision.
Right.
Also, patients are not just seeing us, they're seeing surgeons, they're being discussed at MDTs, and actually the most important thing you learn is where decision-making is difficult, don't do it quickly.
Okay, so give it
time, bring people back.
So I'll hand over to my colleagues with some questions in a second, but I remember one series, I don't know if I'm quoting it correctly, early on in the days of hearing you talk about it, of aortic aneurysm patients who eventually decided not to have their aortic aneurysm repair, and the vast majority died with their aneurysm intact. Is that right? Or is that a bit simplistic?
It's probably right. But I'm choosing my words carefully because we don't have thorough follow-up.
Okay. But many of them decided. What sort of percentage? So some people are now throwing around numbers like over 65 given the opportunity. Is it maybe as much as 15 to 20% of patients given the opportunity not for surgeries?
I think aneurysms is a dynamic process because the aneurysms change in size.
Yep, okay.
The patients change in age. So patients in the UK with abdominal aortic aneurysms are predominantly male. and they're picked up through two processes. One is the screening, the UK National Screening Programme that offers ultrasound screening to all males aged 65, or they present as victims of medical imaging technology, otherwise known as vomits.
Right.
Now, a vomit is where you have some other symptoms, say abdominal pain, and you end up with a CT scan that then finds your aneurysm. Those patients then are seen by vascular surgeons when the aneurysm reaches 5.5 centimetres, but actually we see them earlier. We see them before the vascular surgeons as part of preparation for possible future surgery. So there isn't you see somebody and it's yes, no. There's an evolving process, and we may see people over a 10-year period as their aneurysm changes in size and decision-making changes.
And in the MOOC, the Perioperative Medicine Royal College of Anaesthetists UCL MOOC, I watched a video of you demonstrating a protracted discussion process, which I found very, very educating. It was you didn't get off the fence. You gave them options to go away and think about.
Well, I think that's a very key bit. Is our job is not to give our own personal opinions. Our job is to give people information to help them make decisions.
Mike, your description of how you approach the shared decision-making process, particularly with patients in which having an operation might not be in their best interest, is one that sounds like involves a lot of time. And I think there'll be a lot of people listening saying, well, I would like to do that, but I'm not given the opportunity or the facilities to do so. So what is the setup for you? And if it's different from most people, which I imagine it is, how do you go about getting a similar kind of enterprise?
I think that's a good question. We do not reflect standard outpatient appointments in the UK. We've developed a clinic where we have 1 hour for both a consultation and, if appropriate, a cardiopulmonary exercise test. What I would say, though, is we're doing things different to other outpatients. We screen who we need to see. Right. So in Torbay Hospital, we do about 10,000 operations a year. Now, we see about 850, 900 patients in that clinic. So we're selecting out the either high-risk patients based on age and comorbidities or the surgery. So if you design your outpatient service to what you need, you can allocate an hour.
And who's filtering that out? Is that the pre-assessment nurses, or...?
It's a combination of... we do have some standards for who we should see.
Yeah.
That we can get referrals from the pre-assessment nurses. We do get referrals from individual consultant surgeons, and we get referrals from general practitioners.
And then you also have the opportunity for repeated clinics with patients to see them time and time again as long as needed, or what's...
I wouldn't say we don't set a repeat clinic.
Right.
They may come back the guy in the MOOC, he came back 8 years or 8 years after his original EVAR because there was a complication.
And in setting up the setup you have at the moment, did you have... was there difficulty in that? Did you have barriers that challenged your ability to get that up and running?
I think we've got the advantage of we've been doing it 20 years. So when we started, we actually started with seeing elective aortic aneurysm patients in our own time. And actually we borrowed the respiratory physician's CPET equipment. So we would be seeing people either before their clinic started in the morning or at the end of the day. We then developed with our vascular surgeons a demand, and the vascular surgeons valued what we were doing. And then we moved into colorectal, then we moved into orthopedics. So we've gradually built in a sort of stealth-like way. Where I would say we can justify ourselves is we have outcome data in a publication that says if you went to our clinic, you lived longer. And when we were challenged by the medical director, who's a gastroenterologist, we were able to say, can you demonstrate the benefit of your clinic?
Wow, that's an amazing way the only way to get buy-in there. That's great. It sounds like it's been a real collaborative approach over the years and bringing in the different team members. Can you speak to that a little bit about who that really involves?
I think you need to provide a service to the surgeons that they want, and then you need to develop and learn a way of working together. So, for example, we don't actually attend all the multidisciplinary team meetings that are around surgical decision-making, but we do have good communication through direct face-to-face contact, phone calls or letter writing to communicate what the outputs from our clinic. You also need to actually develop what I would say is a very broad but superficial knowledge of all surgery and all medicine, so that you understand what is in there, what the processes or thoughts that are going on within the different surgical specialties.
Yeah, it sounds like there could be a pretty labor-intensive training for that group too.
I think it's something you learn with time.
Yeah.
And while some of it could be taught, it's actually about building up relationships with your other colleagues.
So, Mike, switching gears just a little bit, you are one of our national clinical leads, co-appointed by the Royal College of Anaesthetists, and getting it right first time, Professor Tim Briggs et al., orthopaedic surgeon.
Yeah. And Chris Snowden in Newcastle
is the other national clinical lead, Chris Snowden from Newcastle. And so tell us just a little bit about what that role is about and what GIRFT, getting it right first time, is trying to achieve.
Start with the college role, first of all. I think our role is to facilitate and help others in the UK or internationally to develop perioperative medicine. Jumping to the GIRFT role, or getting it right first time, is about using NHS data and any other data from things like the hip fracture database, the National Emergency Laparotomy Audit, to look at variation in perioperative medicine outcomes. What we will also be doing, in addition to just looking at that variation, is preparing individual reports for hospitals and then going to visit them to pose questions about variation that is associated with good outcome, to find out what are they doing that gives them good outcome, and then also questioning where there may be not so good outcome and looking at, are there reasons for that less good outcome, and are there things that we can do to help them to improve outcome.
So fantastic. But if you take half the country each, Chris is in the northeast and you're in the southwest, are you going to get around all the hospitals between the two of you?
Yeah, I would like to.
Yeah, I'd put my hand up for that.
I think I'd like to, because you learn a lot visiting places.
Yeah.
With the GIRFT projects, you produce a report.
Yeah.
From other specialties' experience, they found that you start with 2 to 4 initial visits to check your process, and then you start doing what are called deep dives, looking in more detail at places. And most people say that after about 30 visits, you've got an idea of what's going on.
Right.
Now, that may give us enough to start preparing a national report, but we will do as much visiting as they give us time for.
His previous experiences related to this, and people say he's not going to say enhanced recovery again, but I'm going to say enhanced recovery. If you go back to 2008, 2009, the visits were were on the edge of the cloud. So they were what appeared to be the people with the very best results, and what appeared to be the people who might possibly have much less good results as the sampling zones. And that seemed to clearly indicate that there were opportunities to do the same as the people on the cutting edge of the good results and draw the cloud across into that zone. Is it a similar principle, or is it?
I think it's a similar principle, but it's taking it a stage further.
Okay.
If you go back to the atlases of variation that have originally started from North America, John or Jack, I'm going to forget his name, Weinberg.
Right.
Jack Weinberg, I think it is. His ideas on mapping variation were picked up in the UK by Muir Gray, an epidemiologist from Oxford.
Yes.
And that led to the NHS producing atlases of variation that did nothing.
Right.
The difference that Tim Briggs has brought, working with Muir Gray originally, is a clinician visits and talks to other clinicians. So there is a face-to-face discussion.
Yes.
And you can't just have a book or a piece of paper or an email that you just dismiss.
And are you still, some of Tim's earlier presentations, I can't remember exactly how he phrased it, but there was sort of this unit of medical activity, the sort of cost of a day of care or a procedural type of thing that bundled everything in, including how much we're spending on salaries and equipment. Is that still part of the...
It will be. We haven't finalised... In the next 2 weeks, we're going to finalise what we're looking at. Yeah. But things that it is going to almost certainly be is looking at day case rates,
right,
length of stay, readmissions, use of colloids, right, and the costing of the use of those colloids. Hopefully we're going to be able to look at opiate consumption or opiate prescribing in across a whole health organisation. Yes. Now, with those, you can convert them to dollar or pound signs that could be potential savings. But I would put, probably the word is not savings, it's better use of resources. Right. And I think, we need to turn the way we look at healthcare in the same way that we look at the environment. Yes. We need sustainable environment, but we also need sustainable healthcare. We do have a limit of how much money our population is prepared to allocate to healthcare. And I think the getting it right first time process will allow us to optimally use that money.
What's it like working with Tim?
Fun.
I mean, you're on national. I've known Tim for a long time, so
fun is the answer. Yeah. He is challenging.
He's a good man to have on your team.
He's challenging. He's inspiring. He's occasionally exasperating. I would say that if he was sitting next to me.
Aren't we?
Brilliant.
All?
Any final comments or questions? Great for everyone.
That was great.
Thanks very much indeed, Mike.
Thank you so much, Mike.
Nick Majerison here. Thanks for downloading TopMedTalk. TopMedTalk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. EBPOM has been advocating perioperative medicine for many years now, using the traditional conference circuit, where people have attended meetings from all over the world and heard some of the latest information. However, in the face of the COVID crisis, EBPOM took a bold decision. We've transposed the entire conferencing experience into an online experience. Carbon-friendly conferencing. The latest information, the latest talks, the hottest experts, the most incisive analysis, and even the socialising. We've got it all covered as EBPOM goes virtual. Hot on the heels of the huge success of EBPOM 2020 live from London, we're now headed towards EBPOM Chicago. Come aboard and be part of one of the most exciting developments in medicine since the stethoscope. EBPOM Chicago. Get yourself to ebpom.org now and guarantee yourself a place at one of the most exciting conferences in the world.